action. They're not like having to use, you know, and like really huffing and puffing. It's just easy, not even thinking about it. Okay, so posterior thorax, the back. We do have to do lungs on both sides of the body. So when we go to the posterior thorax, first thing you're going to note is skin color. Then you want to look at the structures. So what structures might you look at?
Clavicle.
Not on the back.
Scapula.
Scapula.
C7.
C7.
Is that knot right here?
Mm-hmm. Yeah, you want to look at the spine. So first you want to make sure the spine is straight. That's kind of musculoskeletal, but it does have something to do with this one too, because we know with kyphosis and scoliosis, it can change a person's lung field, so and chest shape. So is the spine straight? Yes. Scapula, are they symmetrical? Are they even? Is one up here and one's down here? If that was the case, what would be going on?
Wait, what?
We have one scapula up here and scoliosis. Scoliosis, yes. All right. And so we're going to note symmetry. We're going to note that, I don't want those to come off. We're going to note that everything looks the same. This guy's he's very particular, so I marked where you can hear things on him. If you don't have it in that exact location, he doesn't work. All right, so then we're going to palpate. You're going to palpate the entire back. We're looking for any masses, any nodules, anything out of the ordinary that we might find gross, and any tenderness. So if they've been sick and they've been coughing a lot, they may be tender in some places back here. So that's something you would be looking for. Yeah, and you get sore in the front too. Yeah. We'll palpate that in a minute. All right. You're going to palpate the ribs and the intercostal spaces as best you can. Now, under the scapula, you're not going to be able to feel those ribs. You can kind of feel them sometimes. And the more padding a person has, the more difficult it is to find ribs. But you do want to try to palpate the ribs and intercostal spaces so you can get an idea of where you're going to be listening, okay? He's really hard to feel. He's got ribs, but they're kind of hard to feel. All right, respiratory expansion. All right, so the way we do that, it's not a good place to show you. I'll show this side, and then I'll show you this side. How's that? Okay, so respiratory expansion. You kind of come at the costal angle right here. You're going to pinch skin up between your thumbs, so there'll be a little fold of skin between your thumbs. All right, and you're going to have it like this with a little fold of skin between your thumbs. You're going to have your person take in a deep breath through their mouth, and when they take in a breath, your thumbs should expand and that fold of skin should spread out. And it should be even on both sides. So one side shouldn't move and the other side stay. Okay? So what you do, for you guys over here, you push in, and in the middle, like right on the spine, you're going to have a little fold of skin pushed up with your two thumbs. When they take a breath, your hands will spread apart naturally. Okay? All right. So it should be smooth, it should be even, it should be symmetrical. So the next thing we're going to do is tactile fremitus. Such a fun thing to do. So what you do is you use your palms, so palms, and you go side to side, or you can do it simultaneously. I tend to do it at the same time. I think it goes faster and I can assess better what's going on. I can compare better when I'm doing it at the same time. So there's no reason, I mean, it doesn't matter, but I do it at the same time. You can do it however you want. And you want to have your person say
99.
99. That's like the magic word with the lung assessment. So
what is 99? What do you say?
Yeah.
You can say 88.
You can say blue moon.
Yeah, you can say blue moon.
111.
Or E.
That's in the UK.
Yeah. We're not British. 99.
In Britain they say.
So we'll have them say 99. Now we go all the way down. So 99, 99, 99, 99, 99, 99, and you're feeling. So what you should, it will diminish. So it'll be, you'll feel it pretty good up here. And then as you move down, you're gonna feel it diminish. It's not gonna be, you're not gonna feel it as much.
It's like vibration.
It's vibrations, exactly.
Can you do 99 this way?
Oh, sure, I'm sorry. So you start at the top, 99, 99, 99, 99, 99, 99. And go all the way down. All right, percussion. This is the one that you're probably going to say some words about because it's a little bit challenging. Percussion's not easy for anyone, especially not at first, so don't get frustrated when you can't do it great. It's okay, you'll get there, you'll be able to hear something eventually, but you may not hear anything immediately. You may not even be able to get any kind of sound out immediately.
Is that what the doctor says? You didn't even listen to it?
No, that's auscultation. Percussion's when you're beating on.
Oh, okay.
Okay? Now there's different ways to percuss, and everybody kind of figures out their own way. All right? I'm not going to tell you how to do it. I want you to do it so that you can hear sound, and you can't, you know, beat on it. So, no bruising the patient. All right, so what you're going to do is you're going to be percussing at the intercostal spaces. So you're going to do 3 positions up here, right along the kind of the top of the scapula. The way you percuss, and my nails are probably a little too long right now to percuss accurately, but I use my knuckle. In the book, it'll show you using like a finger. I use my knuckle because I think I get better sound. So you know, do what you want. Do you hear that? It's easy on him. It doesn't sound that good on real people. Okay, and you percuss all 3 spaces here. Then you go to this side, and you do the same thing. He's at a weird angle. Okay? So starting up here, you percuss. I can't do it good from that angle, but. And you usually are hitting that first joint. I don't think there's a rule that you have to use your middle finger. You could use your first finger if you get sound out better that way. I've always used my middle finger. I don't know why. Yeah, I guess that's why. I don't know. I've always done it that way. When I try to do it with my fingertip, I don't get as good a sound. I don't think. So I use my knuckle, but if you hear good sound, if you have longer nails, it's probably going to be hard to use your fingertip because it's going to hurt and you're not going to get a good sound because there's not. Now, some people will do it with like the pads of their fingers and they can get a sound that way, but you kind of have to press this joint up against the patient, so it's just kind of this part of your fingers touching. You're not putting your whole finger down, okay? Did y'all see? Like you just are putting like this part, like here, all right? Your book has all of the spaces, so it's 18 technically, but since you have to do 3 up here, this is all counted as 1. So these 6 are all 1, okay? And then you go 2, 3, 4, 5, 6, 7, 8, and then 9. So you're percussing all over. And it's in your book. It's on page 427. Resonance is what we want to hear. And I need you to tell me that. You're going to hear resonance over healthy lung fields. Okay? This guy makes all sorts of fun sounds, so you'll be able, he doesn't percuss, but resonance is what you should hear if the person's healthy and you're not over a liver, if you're over a liver or a heart. So in the front, you're going to hear dull when you're over other organs. Unless you're over the stomach, you might hear timpani. Timpani is usually over the stomach. So resonance is what we're looking for. Okay. It's a hollow sound, and that's what you hear in the healthy lung field. So over the back, that's pretty much what you're going to hear, unless you're like you end up over the scapula. You want to try to be on the inside of the scapula. Just right between the scapula and the vertebrae. There's not a lot of space there, but that's what you want to try to be. And you don't want to be over a rib. You want to be in that intercostal space. Okay? So next, you're going to do diaphragmatic excursion. It's not fun. And it really takes a long time to catch on to. You not only have to figure out how to percuss, but you have to figure out what these different sounds are. And with diaphragmatic excursion, sometimes it is very, very hard to catch that different sound. It's not a huge difference. It's not like you go from, you know, this to this. It's not a huge difference in sound. I can't accurately do diaphragmatic excursion on him, but I am going to show you the process. So you're going to go down to about T7. So if you think about where the diaphragm lies, I mean, it kind of runs right along the bottom of the rib cage. But you're going to come down to about T7. So about right in here. All right. You're going to percuss down. So it'd probably be actually about right here. So what you're going to do is you're going to start percussing downward until you hear dullness. He doesn't have a diaphragm. I'm not ever going to get dullness on him. But it would get to a place that's dull. When you get to that place that's dull, you mark it with a pen. Small mark. You don't have to draw on them with like Sharpie or anything. All right. So you mark it. Then you have your client exhale completely. Blow all your air out. Now this is the part that, you know, your client's going to turn blue if you keep having to redo it. So be patient with your partner, but let them breathe too. So if you can't find it, you know, give them a minute and then tell them to blow out again. So then you're going to come down, or you're going to start at your mark after they've exhaled. You're going to begin at your mark and you're going to percuss down until the tone changes. Again, you should be hearing dullness going down, and it should go back to resonance, okay? When it goes back to resonance, you mark it, and then you measure it, okay? Now, normal, healthy adult, most of you guys, it's probably going to be between 3 and 5 centimeters. We have to do it on both sides. It should be pretty even. You shouldn't have 2 marks up here and 2 marks down here. Something's going on if that's the case. It should be even bilaterally, and the measurements should be fairly similar. Now yours might be a tad off because you're learning and you may have missed a little bit where it changed from dullness on one side or the other, but it should be pretty close. So 3 to 5 centimeters is a normal healthy adult. Somebody who's really, really well conditioned and in shape could be 7 to 8. So it could be bigger in somebody who is an athlete, really well conditioned. It'd be interesting to see what Amanda's is. I know she's in good shape.
When they exhale completely, are they to inhale again as we're doing that, or we have to, while they're exhaling, we're percussing?
No, they have to exhale completely.
Before you
I skipped that part, I guess. They have to inhale, so you have them take a breath and hold it, and you percuss down.
Okay.
Then they blow all of that air out, and you start at the mark and you keep percussing down.
They breathe in as they blow it all the way out?
They breathe in first before you ever start.
No, I'm talking about after can they breathe, or they have to hold it?
They have to hold it.
Oh.
They have to breathe in and hold it, and you percuss down to the first mark until you get to your first dullness. Then they tell them to exhale completely, hold it, and you percuss down until you get back to resonance.
Which should be 3 to 5 centimeters.
Should be about 3 to 5 centimeters. It's really not a long time when you know what you're doing, but when you're still learning, it could take a minute.
Seconds in.
Yeah, that's what I said. If you start turning blue,
I'm gonna need a second.
give them a minute. All right. So then we're going to go to auscultation. We're going to use the diaphragm of our stethoscope, big part of our stethoscopes. And you're going to tell me about the bronchiovesicular, the bronchial, and the vesicular breath sounds. All right? You want to be careful because breath sounds can be really challenging. If your scrubs or shirts hitting the tubing, it can make it sound funny. You know, these stethoscopes are pretty sensitive. We've learned that doing blood pressures. Anything makes it make extra noises, so you don't want to be confusing that with, you know, and thinking your patient has crackles when it's you rubbing the stethoscope tubing. If the patient's shivering, a hairy chest can change breath sounds because it rustles under the stethoscope. It says to wet the hair or press firmer. I just say press more firmly. I've never soaked a patient's chest hair so that I can hear better. Now, granted, I worked mostly in women's health. I didn't have that issue, but I don't think I've ever seen anybody be like, all right, well, we're going to, you know, wipe down your chest hairs now. If they're wearing a paper gown or paper drape, that can, you know, make rustling sounds. So you just want to be careful and try to have as quiet an environment as possible so that you can actually hear breath sounds. You are going to have your patient take a good deep breath in and out through their mouth. You listen to one whole respiration in every single spot. Don't let your patient hyperventilate. They might need a minute because it's a lot of, and if you've ever been to the doctor and they make you do that over and over, you start getting lightheaded. So you might have to take a minute. Now, if you're working with an older adult, you really do. You have to give them a break in the middle because they'll start getting really lightheaded. So you want to make sure that as you're listening, you listen to an inspiration and expiration because there's some breath sounds that may only be audible on expiration or some that are only audible on inspiration. So if you only listen to one or the other, you may miss something. You're going to listen in the same spots, except you don't have to do 3 spots across the top like you did with percussion. So you're going to listen in 18 spots, and you're going to go down just like you did and come over to the sides, okay? He doesn't have 18 spots, I don't think. How many does he have? He's only got 12. But that's okay. He's just for practice. You guys have 18. So tracheal sounds you're going to hear above C7. Inspiration is less than, Inspiration is less than expiration. So the time taken to breathe in is going to be less than the time it takes them to exhale when you're listening above C7 and you're getting those tracheal sounds, okay? So you're going to hear a longer expiration. Bronchial sounds are C7 to T3-ish. Inspiration is less than expiration here as well. You have bronchiovesicular that are T3 to T5. And inspiration and expiration are going to be equal at this location. And then you have the vesicular, so these are the apices. It's below T5 to T10 and then around to the sides, the lateral parts of the lungs. And down here, inspiration is going to be greater than expiration. So you're going to hear a longer inspiration and expiration will take less time. Okay, you don't have to time it or anything, but that's just what you should have in your mind, and that's what you should tell me. And you don't want to hear adventitious breath sounds. So you shouldn't hear wheezing and crackles or rhonchi or atelectasis or anything like that. None of those sounds should be evident in a healthy adult. So unless you guys are sick, I'm assuming we're not going to hear anything crazy in any of your lungs. He has all the sounds. So is somebody sick? What do you have though? If it's bronchitis, a lot of times you still don't have really good, you don't have lung sounds because it's upper respiratory, it's not in the lung. And a lot of people confuse that. They'll think that bronchitis, you should have junky lungs, but really you don't because it's upper respiratory. So it's more bronchial. Now if you listen to their right here, that tracheal area in the front, you might hear some rattling, but you're not going to hear wheezing or crackles in the lungs like you would with something like pneumonia. All right. So, still listening. We're going to have the patient do bronchophony, and that's where they say 99 and you listen. It should be muffled and indistinct. You should not be able to hear what they're saying through your stethoscope because you go, you know, we shouldn't be able to hear. Now, if you were to listen to someone, you're not going to ever have a doctor do this, I don't think. But if you were to listen to someone and they were saying 99, and you could pretty much understand it, you could hear it more clearly and distinct, and then say 99, it's not going to be that clear. That's a sign that something's going on. So being able to hear them say 99 is not a good thing. There's something in there that's transmitting that sound easier. Egophony, you're going to do the same thing, but this time you're going to have them say E, E. And it should sound like E. It shouldn't be high pitched like that, but it's going to sound like one long E. They're going to be going E, 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 and in your stethoscope you're going to hear E. Okay. And then whispered pectriloquy, same thing, same spots, but you're having them whisper 1, 2, 3, 1, 2, 3. And this one you can be a bad whisperer. It's not like the whisper test where some of you guys were yelling at your partners, but with this one, don't like try to be, because they're not going to hear it. You're not going to hear anything. So it's a louder whisper.
Are we supposed to whisper 1, 2, 3?
No, the patient whispers 1, 2, 3. And it should be, again, very faint and indistinct. You shouldn't be able to hear much of anything. If you hear anything, it should be very faint, and you shouldn't be able to determine what they're saying. Now, when they're saying 99, they need to say it in a normal tone of voice. You don't want them yelling, because then you're going to hear it regardless, because they're yelling and you're right behind them.
So are you going down all these spots when they're saying? I know, right? It's all right.
It is a lot. It doesn't take that long, though.
I have to find them, but I can't remember they.
Well, you will. You'll find them. They're in the book.
I remember that.
All right. Anterior chest. Very similar. First, you're going to do inspection. So we're going to do these one at a time. First, you do the back, then you do the front. We don't go back, front, back, front, back, front, because you'll get it. It's unorganized. So do all of the back, and then do all of the front. All right. So same thing. First, we start with inspection. Shape. Is it, does it look like a normal shape? Pectus excavatum would be that sternum is caving in. I know a kid that has had that, and he had it fixed in January, I guess. He's like 13. And I don't know if he was having problems or if it was just cosmetic or what. They're missionaries in Siberia, and they came back to the U.S. to have that surgery done. But his was pretty severe, so that may have been, you could definitely tell. If you ever see someone with it, it's not something like you're like, oh, I don't know. Like, they look like they got a cavern in their chest, and that sternum's caved in. Or they might have a ridge down the front of their chest where the sternum is like bulging outward. Okay?
Ew.
That's another one. Sometimes they'll fix that one with surgery. That one doesn't tend to cause as many problems, I don't think, as pectus excavatum. But then you're going to also look and see, do you notice a barrel-shaped chest? Does it look like their ribs are round? Can you see, if you can see their ribs, is it sloping, are they sloping down? You're going to be looking for level of consciousness, looking for color. And during this part, you can look at lips and see if they're blue. You would want to look at nail beds during this one to make sure that they are not blue and that nails aren't clubbing.
Like mine.
Like hers, because she's got something going on. You're going to look for any lag in chest expansion. So when they're breathing, does one side really expand and one doesn't? And their facial expression, do they look like it's just the hardest thing in the world for them to breathe right now? Do they look scared? Do they look fearful? Do they look like they're in pain? Do they look upset or nervous or whatever? Or do they just look like, hey, I'm here for an exam, hurry up? Then we're going to palpate. Same thing, you're going to feel for masses, lesions, any of that. You're going to do tactile chest expansion again, same way you did it on the front. So you'll push together that little bit of skin right here. Have them breathe, take a deep breath in, your hands will move apart. It's the exact same way you did it in the back. I think I said front a second ago. But it's the exact same way. Same thing.
What is that?
The chest expansion where you pinch up the skin between your thumbs. Have them take a deep breath and your hands will expand. And then you're going to do tactile fremitus. So feeling, have them say 99. And you go down the locations. There's not as many. There's only 8 places. There's only 8 places on the front that you have to feel. There's just not as much surface area that's not obstructed by breast tissue and hearts and livers and stomachs. Huh?
You feel the boobs.
Well, you kind of move those out of the way. They kind of have to be shifted. to one side or the other. Because, well, like, so you feel here, that's the first position, it's like right here, kind of right under that clavicle. Then you're going to go down and it's kind of right on top of the breast tissue. So it's right here. It's not down over it. The third position kind of is. So on a female, you would come to the inside. Okay? As best you can. Now, if they're really large breasted, you may not even be able to do that position. I mean, honestly, it may be almost an impossibility to be able to feel anything because they have too much breast tissue. 4 would be just under the breast. So you don't really have to lift it up even. I mean, you kind of go right here, like right under the bra line. And that's it. So 3 is the most difficult one for when you're assessing a woman. The third position is going to be the hardest. But you're really, you can't feel anything over breast tissue, so you're not going to just like press over the breast. I mean, it's not going to do you any good. You have to come to the inside and shift them to one side or the other.
Move over.
You have to move them over. Yeah.
Hold your boob while I do right here.
And honestly, people don't even pay attention to it a lot of the time. I mean, honestly, you're probably never going to do tactile firmness. But when you're listening, when you will listen to the chest of females routinely, and you have to displace the breast to listen. And I have never in my life had anybody think that that was odd. My doctor does. She doesn't tell me. She just listens.
So, okay, I'm going to listen to you. She goes, okay, breathe in. Okay, I'm tired of this like 2 times.
I mean, she moves things around, shifts things wherever she needs them. She never says, hey, I'm about to move things. I mean, most people just don't pay attention to that when, you know, if you just started groping, they might. But when you're listening with a stethoscope, they just, you're doing what you need to do. They don't. Now, if it was a young, like a teenager, or maybe even like a young 20s, early 20s, I might say, for this exam, I have to do this, just because they're more self-conscious. I would say teenagers are more so than 20s. By that time, you've pretty much got it under control.
Well, but if they're a young teenager, there's probably not that much to move.
You'd be surprised.
Oh no, my sister is 18 and her boob is she's like
I was thinking
double,
like 13, 14.
Oh, you'd be surprised.
She's a double G.
Who is?
My sister is. I'm like, girl,
G.
Can you say G? Cut off something, give me some, please. But I mean, it's like they're for her size, they're not like
18. She said.
But they're big though. I just look at them like.
You'd be surprised. My daughter's 9, and there are girls in her school that are her age, in her grade, that are fairly well developed for a 9-year-old. I mean, they're not full
Yeah, my
grown.
sister had boobs when she was 9. I mean, my mama took her to the doctor and thought that she was having problems because they were so small.
It's the hormones in the chicken.
Yeah,
That's all it is.
Somebody said it was like, you know how they spray the cow manure. If you smell that, it makes it your hormones grow faster.
Chicken
I used
hormones.
to try to smell it. Yeah, big boobs.
And for a while, I was only
Nothing
going to
happened.
feed my kids organic chicken so they didn't have those evil hormones. But organic chicken costs a lot, and the hormones are cheaper. So
And they're getting something. You know?
Just like eating healthy costs more than eating unhealthy.
yes, I mean, those hormones, to take those hormones away, sure does cost a lot of money.
Yeah.
You'd think it costs more to put the hormones in, but no. All right, sorry, we get off topic sometimes. All right, so we've palpated, we did chest expansion, tactile firmness on the front. Then we're going to do percussion, same thing. We're going to hear resonance to dullness. You do not, I'm not going to make you do diaphragmatic excursion on the front and the back. You can, but I won't make you. So it's a tough one anyway. I figure if you can do it in one place, you're doing pretty good. And on the front, it's even more difficult because you've got the liver in the way. So I mean, it's darn near impossible on the front. So we're going to percuss, and we're going to percuss in those same locations. But there's actually 10 because when you percuss, you're going to do the 4, and then you're going to come over to the side a little bit, okay? Kind of that anterior axillary line. So right right in here, you would percuss again. So you have your fourth, and then you come over a little bit for that fifth one, okay? And you're going to percuss the same way. Now make sure you're percussing in intercostal spaces. Again, if you're percussing over a rib, you can't percuss over breast tissue. You don't want to percuss over breast tissue. But I mean, you're not going to hear anything anyway. So you really want to be careful not to percuss over the breast tissue. And you want to realize that there are other organs in the front that are going to interfere. So you're going to hear dullness here. Why? What's here? The liver. The liver's here. So you might hear some dullness in there, and that's okay. It's the liver. You might hear some dullness on this side. What's up here? Heart. You might hear some tympani right here. Stomach. Yes. So just know that there's different things on the front that might make those sounds a little bit different. You still shouldn't hear hyperresonance or anything like that. Then you're going to auscultate the same places. You're going to still do the, tell me if there's adventitious sounds or not. You're going to tell me if there are the tracheal. So you'll listen here on the front where you didn't listen, to the back of the neck. You'll listen right here. And then you come over to the clavicular. So you listen at the trachea, and then you listen just under the clavicle, and then you move down, okay? Again, you have to displace breasts. You can't listen over them. You're not going to hear much. So you'll hear the tracheal sounds here, bronchovesicular sounds at the first and second intercostal spaces, and then vesicular sounds are going to be on the rest of the lungs, okay? Now, if this was a baby, obviously you're not going to have a baby breathe in and out. But if it was a baby, what are some things that we would know to do, that we would be expecting?
Right.
If they're brand new, fresh out of the womb, then they might have some crackles.
It may be hard to listen because they can't breathe through their mouth. Right?
They cannot breathe through their mouth. Remember that. They cannot breathe through their mouth.
Like 3 months?
3 months. They're obligate nose breathers. If a baby's nose, if you hold a baby's nose, it will suffocate. If this baby's nose is blocked, it can't breathe. So choanal atresia is when a baby's born and the structure and anatomy of the nose, it's blocked. We catch it, we don't routinely, feed anything through a baby's nose to see if it's patent. So what you find with these babies is they're crying and they're pink and they're happy, but they settle down and they start turning blue. Because when they're crying, they are, they're crying, they're breathing through their mouth. Not consciously, but they are just because of what they're doing. When they're not, they have to breathe through their nose. They don't know how to breathe through their mouth, and they'll turn blue. You rustle them around and get them crying again, and they start pinking up. So that's how we usually catch that, and then that's our sign to see what's going on.
What would they do to
They do surgery. They have to intubate the baby until surgery, though. Baby has to be intubated because it won't breathe otherwise. So they'll intubate. Remember, too, that a baby's chest is going to be naturally barrel-shaped. That's normal. As they grow, about 6 years, that kind of evens out.
my daughter's stomach is like, it just be round. Like, why does it
Well, that's her
round?
stomach. Her chest should be.
Would it be easier to use than would it be?
You can hear pretty well on a baby, but, if you think about this is almost, that's a good portion. So if you can find a newborn stethoscope or neonatal stethoscope, they're a little bit smaller than a pediatric stethoscope even. They're only about this big around, maybe a dime size, between a dime and a nickel size. It makes it easier to locate things and listen more accurately. Older person, you may have kyphosis. That's the humpback, the very top of the spine. That can create a barrel chest appearance. If someone is acutely ill, they can't sit up, you can either have a second person come in and help you support that person and hold them up, or you can roll them side to side. But just know, when you're having to roll them side to side, you can't compare sides, for one. and it can put pressure on the lungs, so it's harder for them to take deep breaths because there's something pressing against them. What else? Barrel chest, that's common with COPD. We said that. You'll also see people with COPD doing pursed lip breathing because they can blow more air out that way when they're doing the pursed lip breathing. They're able to blow more air out, and so it makes it a little easier. All right, so this guy, he has lots of different lung sounds. He has heart sounds too, but we're not going to do those this week. You'll be able to hear them if you move your stethoscope over it, but I can't turn them off. But I put little stickers here because you have to use this stethoscope if you want to listen to him. And you have to have this stethoscope in exactly the right place. If you're off by a centimeter or two, it doesn't do anything. So I put the stickers on here because the purpose of this is for you to hear adventitious sounds, not to try to make you find his exact locations. So I do want you guys to listen. He's got the posterior and anterior. If you don't hear it right over it, just move it around just a small bit. I tried to put them as accurately as I could. So here's all the different things that he's got. He's got, you can listen to an infant's breathing. Their breathing's irregular. They may breathe really, really fast and then breathe slow and then have a minute of apnea. Not a minute. They may have like 10 seconds. May have like 10 seconds of apnea and then breathe really, really fast again. So it's really irregular. But it's got normal breath sounds. You can listen to the bronchovesicular breath sounds, bronchial. You can listen to a friction rub, egophony, pectriloquy, stridor. Stridor is unsettling. It is. Stridor's unsettling for, yeah, it's usually obstruction, but you hear it a lot with croup as well. And it's probably the most unsettling breath sound because you can hear it when they walk in the room. You don't really need a stethoscope to hear stridor usually. They have normal vesicular, they have wheezes, fine crackles, coarse crackles, rhonchi, which is like snoring. Pulmonary edema, so you can hear what that sounds like. And then the back is the heart sounds, so we don't need those today. We'll use those next week. But the way you do it, the way you can set it and to listen to different sounds, they're numbered on here. And here's his little remote. All you have to do is push the lung button and then push the number, and they're also on the remote here, of what you want to hear. And then hit enter. Give it a second to change. And then when you put your this stethoscope on here, then you should be able to hear those sounds, okay? Front and back. So he's good to, especially if you want to know kind of what some of these sounds sound like. I also put on Moodle a link to a website. So when you're at home, it's got lots of different, it's got all the different breath sounds on there that you can listen to. So you can listen to them on your computer. Obviously, you don't have to have a stethoscope for that. But if you're wondering what something sounds like or you can't remember, you can listen, go to that website. And you'll want to keep that around because it'll be useful next week when we do heart too, because it's got heart sounds on it as well. This guy will be out for you guys to come in here and practice with. I'm not going to put him up. Don't steal him. Don't take him home. Yeah, right? What about HOV lane? But he'll be out, so you guys can come in here and practice with him if you want to. You can also use him to do just, if you're just practicing an exam and you don't have anybody to practice with, I mean, you can use this, it's just the thorax. You can't do the pinching up thing, but you could use it just to go through the motions if you needed to. The hardest part of this exam is getting percussion down, okay? That's going to be your toughest thing, is getting that percussion down. Listening for that dullness. If you need to go, if it takes you a minute to figure that out, that's okay. If you can't find it at all, if you're doing your best and you just really cannot hear that, As long as you can tell me what you're supposed to do, tell me what you're supposed to hear, tell me what you expect to find, I'm okay. But you have to give it an effort. You can't say I can't do it and just, you know, like moving on. You have to at least give it a good effort, okay? But practice that. Practice percussion. It is not a skill that you're born knowing. It's not as easy as sticking a stethoscope on somebody's chest and listening. You have to practice it to get it down. It just takes some time. We're going to be doing it not next week, but definitely we do it again. We percuss again when we get to abdomen. So if we do it next week, it's because we have to percuss heart borders. I can't remember if that's included or not. But definitely when we get to abdomen, we're going to be doing it again. So you got to get it down, and you'll have to do it on your final checkoff too. So working on that, trying to get some sound out. Do different ways, see what works for you, find a way that works for you, and go from there, okay? If you just are not figuring it out, come see me, and we'll work together, and we'll figure it out. We'll get sound out of your finger. But yes, and you can even, I mean, you can percuss on him. Like I said, you get a lot more sound out of him because he's a hollow chest than you do out of a real person. But you can practice on him. There's no harm in practicing, okay?
But for the checkoff, we're doing it on the person.
Yes, in checkoffs, you're going to be doing it on your partner, just like we've done all of our other
I'm
checkoffs.
gonna be able to like keep her shirt on.
Yes.
Okay. Just making sure because
You know, with the shirt, it's like, it gets in your way. That's what she's trying to say.
If you can wear a tank top next week, that's great.
If it's cold, it might not happen.
Well, even if it's under your scrubs.
Okay.
I mean, you could just throw a tank top on under your scrubs. That makes life easier. When you could bring somebody in to check off, have them wear a tank top and shorts. Don't bring them in jeans and a sweatshirt.
It's gonna be November. They're gonna be cold.
Well, they can change, or they can wear it under their clothes, but you have to be able to get to them. I mean, that's a big part of your grade. If you don't pass that, you fail. So,
My mom's like, if I have a gown, I'm fine. I don't care.
yeah. So you tell them you have to change or do something.
My purse is because my mom.
When we do abdomen, the week we do abdomen, we are going to have to be able to access abdomens. So you will pull your shirt up a little bit that week. We'll pull curtains, and we're not going to use you as a demonstration, but
Don't look at that.
Don't look at the back.
it'll be all right. That's right. So that's the only week, you have to really expose any skin. But you'll be okay. Like I said, you can pull curtains. You don't have to do show and tell. But yeah, if you can wear a tank top next week, I would probably be easier. No show and tell.
So, yeah.
All right, guys.